Hello and welcome to today's episode of the VJ Hemonc podcast. Our focus in this episode is FLT3-ITD mutated acute myeloid leukemia. We will be covering the standard of care for frontline treatment, key trial updates including an analysis of the Quantum First trial, and the use of MRD using FLT3-ITD as a marker. First, let's begin with Amir Fathi, who discusses the standard of care for patients with FLT3-ITD mutated AML in the frontline setting.
The current standard approach in younger patients with FLT3 mutated AML is in the United States, intensive chemotherapy plus a FLT3 inhibitor. The most common form of intensive chemotherapy is 7+3. And there are two drugs that are approved, midostaurin and quizartinib, that are initiated on day 8 of 7+3. So they're combined with 7+3 or other intensive regimens in FLT3 mutated younger patients who are eligible for intensive therapy. For older patients or those who are not eligible for intensive therapies like 7 and 3, there is really not a standard approach that incorporates FLT3 inhibitors. You can use HMA and venetoclax, but the data is kind of mixed, particularly when it comes to FLT3-ITD mutations. I'm conducting a large randomized study, not in FLT3 mutated patients, but in upfront younger patients to bring HMA venetoclax as a potential option in younger patients. It's approved for older patients. I want to see if in younger patients it could be equally efficacious, given that it's milder and maybe less toxic, much less toxic than intensive therapies. And over time, perhaps, we can use HMA venetoclax as a scaffolding, as a sort of a baseline to then add novel therapies like FLT3 inhibitors, IDH inhibitors, menin inhibitors, to sort of allow a more gentle approach for younger patients and older patients to potentially benefit from targeted agents in the upfront setting.
As Dr. Fathi mentioned, the field is moving toward combinations that include a hypomethylating agent, venetoclax, and a FLT3 inhibitor. Now let's hear from Musa Yilmaz, who discusses a phase 1-2 trial exploring decitabine, venetoclax, and quizartinib in newly diagnosed FLT3-ITD mutated AML.
So this is a phase 1 and 2 study of decitabine, venetoclax, and quizartinib triplet combination FLT3-ITD mutated AML. So in this study, we treated both frontline patients, newly diagnosed patients, also relapsed refractory patients. So in the frontline arm, for the sake of time and brevity, let's focus on the frontline arm. So we have treated 30 patients in the newly diagnosed cohort, and these are the patients with the median age of 74 years old. So those are the patients that are not eligible for intensive chemotherapy. That's why they are on this program. So they have received this triplet combination in the phase 1 and phase 2 component, but mostly phase 2. And the recommended phase 2 dose for the quizartinib of this triplet is 30 milligram. We have tried up to 40, but it created prolonged cytopenias in these patients. So that's why we had to reduce the dose to 30. So quizartinib 30 milligram, venetoclax, and decitabine. So with this induction regimen, 94% of the patients achieved composite CR and 70% achieved complete remissions, meaning bone marrow going in remission plus counts recovering to normal ranges. So also we have looked at MRD in these patients, the minimal residual disease by flow, and also PCR. And we have seen after cycle 1, 60% of the patients achieved MRD negativity. And with the following cycles, the MRD negativity got even better, up to 80%. The second point that the second important key point from this study is that the overall survival in the newly diagnosed cohort, the median overall survival is not reached, and the median follow-up is 17 months, and 1 year overall survival was 72%, which is pretty good compared to the patients who receive only HMA ven or only HMA plus FLT3 inhibitor, which is usually less than 1 year. I'm specifically talking about FLT3-ITD mutated patients. So that study shows that we can improve survival in this patient population.
Next, we turn to the phase 3 Quantum First trial, which evaluated quizartinib plus chemotherapy in newly diagnosed disease. Mark Levis provides an updated analysis, highlighting which patient subgroups benefited the most and which didn't, particularly in the context of co-occurring mutations.
So this was really looking into trying to explain why certain demographic groups didn't do as well in Quantum First compared to others, specifically the older patient population. Patients under age 60 had a clear benefit from the addition of quizartinib to induction consolidation chemotherapy. Older patients, clearly not. But FLT3-ITD mutated AML is not one disease. It occurs with other mutations, and they have specific clinical behaviors. So with this difference in older patients, we first looked at MDS-related genes and did not see any obvious association with one MDS-associated gene. However, we then looked at the concept of this triple mutation, DNMT3, NPM1, FLT3-ITD. That had been reported to do very poorly with intensive chemotherapy alone, remarkably well with a FLT3 inhibitor in the salvage setting. So when we looked at the quantum first data, we saw triple mutant patients, DNMT3, NPM1, FLT3-ITD, did very poorly on the placebo arm, more poorly than patients lacking the triple mutation on the placebo arm. So yes, we've confirmed it's bad. B, quizartinib versus placebo had a dramatic difference in these patients, benefiting the triple mutation. And then we asked, okay, well, DNMT3A is a common founder mutation, but there are other associated epigenetic founder mutations not dissimilar in function, TET2 and the other components of the complementation group, WT1, IDH1, IDH2. So let's look at those with an NPM1, with a FLT3-ITD. It gets a larger group. All of those seemed to benefit more dramatically than with quizartinib. Finally, we turn back to our age question. Older patients who have this subtype of epigenetic regulator, DNMT3A, TET2, or whatever, NPM1, FLT3-ITD, actually do benefit from the addition of quizartinib versus placebo. So it really gets to, you should not look at FLT3-ITD disease as a single entity, but what is the context it's occurring in? The older patients with MDS AML with a FLT3-ITD probably shouldn't be treated with intensive chemotherapy anyway, whereas a more fit but patient over age 65 who is fit enough for intensive, who has the triple, as we might call it, probably should get intensive therapy plus quizartinib.
Building on this, Harry Erba compares findings from the Quantum First trial to those in the Quantum Wild trial, which evaluated quizartinib in FLT3-ITD negative patients.
Well, the Quantum Wild trial has been informed and started because of the work of Paolo Montesino and his colleagues in the PATHEMA, a group of clinical investigators in Spain and Portugal. We have known for a very long time that quizartinib has in vitro activity against wild-type normal FLT3. And this was seen in the initial phase 1 study where we had a small group of patients in the dose escalation who did not have a FLT3 mutation. We've gone back and checked those by a very sensitive MRD assay. They truly didn't have a FLT3-ITD, and yet we saw responses. And so we know that this drug binds to the inactive conformation of FLT3 and so may prevent activation of FLT3 by the FLT ligand, which often is upregulated in patients receiving intensive chemotherapy. Furthermore, there's retrospective data showing that the expression level of FLT3 wild type on AML blasts correlates with outcome. There's also clinical data to suggest that FLT3 inhibitors with a type 2 inhibitor may actually be beneficial. For example, the SOAR AML study that's been published by Christoph Rohlig and his colleagues showed that there was a leukemia-free survival in all patients receiving intensive chemotherapy with sorafenib versus placebo. The study was not powered to look specifically at a FLT3-ITD group, but the entire group, there was a leukemia-free survival, not an overall survival. And so based on that, Paolo Montesino launched a trial in patients eligible for intensive chemotherapy up to the age of 70 years old, where patients without a FLT3-ITD, they could have a FLT3-TKD, and about 25% of them did, were treated with 7-3 chemotherapy with quizartinib at a slightly higher dose than used in Quantum First. It's 60 milligrams. I guess that would be the equivalent of 55 milligrams in the FDA labeled formulation. once daily on days 8 through 21. And they could then get high-dose cytarabine consolidation with quizartinib and continue on a maintenance. They could get transplant at any time. And this was versus a placebo. And what has been presented and soon to be published is that there was an improvement in both overall and event-free survival with the addition of quizartinib in these patients who did not have a FLT3-ITD. What's interesting about that analysis is when they looked at both younger and older patients, there was a survival benefit. So unlike Quantum First, there was a survival benefit. And the second is they did not see what we saw in Quantum First. They did not see that early drop in survival with quizartinib, especially in the older patients. And I think this really speaks to the importance of looking at the supportive care that patients with AML get. And it's a distinction between a large global international study like Quantum First and a study done by very learned leukemia investigators who work closely together. They have standardized protocols for supportive care on their AML trials in the Fathi group. So I think that's an important lesson. So age didn't matter. What did matter in their subset analysis was that there was only a survival benefit as well as a relapse-free survival benefit in patients with either favorable or intermediate risk disease by ELN 2017. In ELN 2017 adverse risk, they did not see a survival benefit. As a corollary of that study, investigators have determined that there is a FLT3-like expression signature found in AML blasts in patients in samples that don't have a FLT3-ITD. When they then applied that signature to their population, they found that the patients with the FLT3-like expression signature were the ones to have the survival benefit. There was no benefit if they didn't have that. And interestingly, that expression signature was enriched for patients with NPM1 and DNMT3A mutations. So that's the foundation of Quantum Wild. We are basically going to replicate that study with patients up to the age of 70 fit for intensive chemotherapy without a FLT3-ITD, randomized to get standard 7 and 3 with HiDAC with either quizartinib at 60 milligrams daily or with placebo. The primary endpoint of the study is a survival endpoint. We also have an arm C in there where patients who are initially getting quizartinib during induction placebo will not get it during the maintenance to give us maybe some data at least on the importance of continuing quizartinib as a maintenance at that point. I'd like to finish with a shout out to Mark Levis, who will be presenting molecular data at this Congress on Sunday, July 14th, something like that. No, 15th, June 15th. He's presenting molecular data showing that in patients in the Quantum First who had FLT3-ITD, NPM1, and DNMT3A, there was a significant survival benefit of quizartinib versus placebo. And this was seen also in the older patients. And so instead of being ageist about which patients should get quizartinib if they have a FLT3 mutation or otherwise, and we should be thinking, are they fit for potentially curative intensive chemotherapy, regardless of age, especially if they have a genotype that suggests that long-term survival is possible after intensive chemotherapy with quizartinib, with or without allogeneic transplant.
Finally, let's shift our focus to measurable residual disease. Dr. Yilmaz shares his perspective on the role of MRD monitoring in the management of FLT3-mutated AML, followed by Dr. Levis, who presents findings from a post-hoc analysis of the Morpho trial, which looked at the impact of conditioning intensity and NPM1 co-mutations on MRD status in patients undergoing allogeneic stem cell transplantation.
So the MRD is very important. Right now, obviously, it doesn't dictate how we do induction and consolidation. We like to see if our patients achieve MRD negativity. For example, for FLT3, now we have much more sensitive assays, the NGS assays, and we can detect the FLT3 at a sensitivity level of 10 to the minus 5, 10 to the minus 6. So patients who achieve MRD negativity, we know that the risk of relapses in general is lower in these patients. But For the FLT3 purposes, obviously with the FLT3-ITD mutated patients right now, the general consensus is that they proceed with allogeneic transplant as a consolidation treatment. So, and when they go to transplant, we do FLT3 MRD assay before transplant and after transplant. And particularly patients who have MRD positivity in peri-transplant era, before or after, we know that the FLT3 inhibitors benefit. For those patients, it increases the risk of relapse. It decreases the risk of relapse in these patients. That's why we like to use FLT3 inhibitors. However, patients who already achieve a deep MRD negativity, the benefit of FLT3 inhibitors are not clear at this point. So technically, if they are MRD negative, adding a FLT3 inhibitor, I'm talking based on the data from Morpho trial with the gilteritinib, we know that the overall survival is overlapping on those patients. But right now, if they are MRD positive, yes, it dictates how we treat. We do put these patients on FLT3 inhibitors as a maintenance therapy after allogeneic transplant.
So that was we did a post-hoc analysis looking at conditioning in intensity. Patients on that trial received either myeloablative or a reduced intensity conditioning. 60% received myeloablative, 40% reduced. And there is a general thought in the field of transplant that myeloablation is always better than reduced intensity conditioning if a patient can tolerate it. However, that's again lumping all of AML into one category. And in fact, it isn't one disease. So when we looked at this by mutation subtypes, NPM1, again, is a unique category of AML. The NPM1 mutations drive expression of FLT3 and tend to generate a FLT3-addicted clone. If you wish to decide whether or not to give myeloablation, you also need to take into account if the patient needs to have post-transplant maintenance with a FLT3 inhibitor. If they get myeloablation, it's harder to do because the patient is often sicker and can't start the drug sooner. And in fact, when we looked at this post-hoc analysis, patients with an NPM1 mutation didn't benefit at all from myeloablation, irrespective of young or old. They really needed the FLT3 inhibitor. So the post-hoc analysis suggests that for NPM1 mutated FLT3-ITD AML, you should not be using myeloablation at all. But then that gets into the next component of the argument. Myeloablation is supposed to eliminate MRD. But we had a direct way to test this. We had MRD measurements by this FLT3 MRD assay pre and post-transplant, immediately before getting conditioning, immediately after. And so we asked the simple question, well, if myeloablative conditioning works so well to eradicate MRD, let's compare MRD pre and post conditioning. We have myeloablative and non-myeloablative. And there was not a whit of difference between the two. Myeloablative conditioning did not eradicate MRD any better than reduced intensity conditioning. Again, turning that concept on its head. No, you're wrong. Myeloablative conditioning may be a good idea for some, but not specifically for the FLT3 NPM1 mutated AML.
That's all the updates we have for you today. We hope you found them useful. Don't forget to follow us on X at VJHemonc and subscribe to our podcasts on Spotify, Apple, or Podbean. Until next time.